Now we're going to look at a series of macro interventions to reduce healthcare costs, changing how we buy health insurance and also changing the rate of inflation in Medicare programs. Probably the most important is the Cadillac Tax, and this relates to what we have talked about before, the tax exclusion. Remember, when an employer sponsors health insurance and pays part of the premium for a worker, the part of the premium paid by the company doesn't count for income or payroll taxes for the individual. And this has created a perverse incentive. Because $1 in health insurance is worth more than $1 in wages, there's been an incentive to have ever more insurance, and this actually drives up healthcare costs. The Cadillac Tax is the provision in the Affordable Care Act to address the tax exclusion. Basically, it puts a tax on any very expensive health insurance plan. There's a 40% tax for an expensive health insurance plan above a threshold. And that threshold in 2018 would be $27,500 for family coverage. Now, that threshold increases every year based on inflation, and it has special provisions for people who are likely to have higher cost health insurance through no fault of their own. Retired people over 55. Individuals who are in high-risk professions and therefore have higher health insurance bills, like policemen and firemen. And then companies who have higher healthcare costs, maybe due to the aging of their workforce, they are protected from the Cadillac Tax. Importantly, a lot of people think the Cadillac Tax is about raising revenue. But as we discussed, changing the tax exclusion is not just about raising revenue. It has an important downward price pressure effect, incentivizing employers and insurance companies to offer much more cost-effective insurance plans. And this should change and reduce healthcare costs. A second major provision of the Affordable Care Act related to cost control and transforming how we deliver care are accountable care organizations, or ACOs. Now, ACOs are networks of physicians, hospitals, other providers like home health care agencies or rehabilitation hospitals that are supposed to take care of patients from start to finish, from primary care to specialist care to hospital care to care at home after patients have been discharged. And the idea is to have them coordinate and deliver care more efficiently, especially for patients with chronic disease who use a lot of the healthcare services. Now, in the Affordable Care Act, Medicare is supposed to test out these accountable care organizations, trying to move them away from fee-for-service, incentivizing them to save more money. The accountable care organizations are supposed to redesign how they deliver care and thereby keep the quality up, if not improve it, and also reduce costs. Well, with the passage of the Affordable Care Act, there have been the creation of hundreds of accountable care organizations. Not just those that work with Medicare, but also a lot of accountable care organizations that are now working with private insurance companies, again, to try to transform how care is delivered, to improve the quality and reduce the costs. Another way of transforming the healthcare system is IPAB, or the Independent Payment Advisory Board. Now, for years, there has been something called MedPAC in Washington, the Medicare Payment Advisory Commission. It is a commission that advises Congress on how to improve the Medicare provision. And a lot of its reports are very good, but they gather dust because Congress is not required to pay attention to them. So we thought in the Affordable Care Act we would create a backstop, an organization that made recommendations on how to improve Medicare that would go into effect if healthcare costs were going up and up and up, that Congress had to listen to. So the IPAB includes experts in healthcare policy who are appointed by the President and confirmed by the Senate. And they are supposed to make recommendations on how to improve Medicare and keep costs down if Medicare spending is going up too fast. And the government must implement those provisions unless they provide substitutes that'll save just as much money. Beginning in January 2018, the IPAB is supposed to make recommendations if healthcare spending goes up faster than growth in the economy plus 1%. As I mentioned, Congress can overrule the IPAB recommendations, but only if it comes up with alternatives that cover as much money. Now, there are restrictions on what IPAB can do to try to save money. It can't ration care. It can't raise revenues or increase the premiums paid for by Medicare beneficiaries. It also can't change the deductibles or the coinsurance paid for by Medicare beneficiaries. It can't change the eligibility criteria or restrict benefits. So really what the IPAB has to do is incentivize transforming how care is delivered, transforming how doctors and hospitals care for patients to make it more efficient and high quality. We've looked at a whole series of macro interventions aimed to keep healthcare costs under control. But they can only be effective if they're translated into a change in how we actually deliver care to individual patients. Next, we're going to look at some of the ways to transform that care delivery system.